Hi guys, welcome back to Connect Conversation styled by Infinite Gents Grooming. Today joined by my good friend Mr. Gillan Coats. How are we, mate?
I'm alright, mate. Thanks for having me.
No, pleasure. Obviously going to get right into the kind of NHS, doctor side of things. So talk to me, what inspired you to pursue a career in medicine?
A few things really. So my brother is quite severely disabled, so I've kind of always grown up seeing him getting a lot of, care needs, things like, even like personal care, like his schooling and all that. So, and he obviously had a lot of involvement from various like roles within the NHS, So I suppose I grew up with that kind of care aspect. So I think that kind of inspired me a little bit.
Would you say that was the main kind of thing that drove you?
That's what I put in the personal statement anyway, yeah. But yeah, I think it did more than I realised, to be honest, yeah. Because I realised that, there's plenty of others out there that maybe don't have the support of a family that he does, or there may be others in need, and I thought I could do my bit to help them.
Yeah, how was medical school? What was that like? Because a lot of people I hear different people talking about it, and it sounds grueling. It sounds quite tough. But I don't know if that's from my background, not being very good with education or stuff like that. So I don't know. How did you find it?
Yeah, it's kind of its own beast in terms of education as well. It's separate from even other courses, which I don't like, because it kind of keeps you just like, oh, that's the medical school, they're the medics. But yeah, because it's very different, because every other course you do seminars and you do classes and lectures, whereas like medical school from day one, depending on where you go, they put you on placement, or it's the actual structure of the course is very, very different, and obviously it's 5 years compared to the usual 3 or 4. And the latter half is just all placement. So you're essentially just been put on the wards, and you're kind of learning that way, because that's how you need to learn. Like, you can't learn medicine in a book. No matter how hard you try, you need to do it.
Just for a lot of things, the doing is the actual the bit that's most important. It's not just it's easy to read off a book, but the actual doing it in person's the hardest. But how did you find that then, going and doing that on site?
I think it's much better. For example, you could learn about a specific disease, and it kind of makes sense in your head about how you would manage it, and then you see it in real life, and you kind of see what they've done, and you go, oh, that now makes sense. And once you've kind of gone through the patient's notes, spoken to them, and you go, oh, I know how to manage that now because I've seen it, and you kind of remember that one. I think for a lot of conditions, folk have one patient in their head that goes, oh, I remember that one and how they were managed, and then it helps you for subsequent ones.
Yeah, class. And obviously another thing, another kind of string to your bow, if you like, is a karate. Karate expert, would you call yourself an expert? Because you obviously done it for a long time.
Yeah, I mean, I started just before I was 8, so I suppose I'm doing it, I'm doing it for 20 years now. Maybe not so much in the past couple of years because of work, but yeah, I've been doing it a long time.
Yeah, and do you feel that there's comparisons you can draw between maybe the discipline of karate and then being a doctor?
Yeah, I mean, I think it's good for a number of reasons. I couldn't recommend martial arts more to people as a pastime, as a sport, whatever you kind of want to class it as. I think it's very, very good at teaching discipline. It's particularly good for wee ones, even wee ones that are maybe struggling, maybe on the autistic spectrum, and they kind of need a lot of routine. So it actually it fits in quite well with them, because you learn very specific ways of doing things, and it's quite pattern focused. But on top of that, I've got a great group of friends that I still speak to that I've known for 10 plus years through karate. Yeah. You get a lot of role models as well in your instructors, and it's great for fitness as well. I owe most of my fitness to doing karate, and probably most of my work ethic, because it is kind of very individual as a sport. So I suppose you get used to being very critical of yourself in the way that a lot of professional athletes do. It's this kind of same mindset. I suppose you can transfer that.
Do you use it as any party tricks? Like, how you see
I could.
I do, Chuck Norris, you see it on the TV and he goes like with ice, or you see it actually in a lot of the movies when they get chop 6-7 blocks at one time.
Maybe
you've told me a couple you've done.
I can do it in my head. I can't do it too many times.
What, a headbutt and then break it?
Yeah.
And what's that? What are you breaking?
It's just a plywood. It's
How
nothing.
thick?
you're lucky if it's an inch thick. You know, it's not, but it's
still
solid. It's more, that's more mental. Do you know, like, you could do it. It's just the mindset of like thinking, I'm going to put my head through this.
Yep.
And if you hesitate, you won't do it. And that's the same for any of the board breaking. It's a specific subset of karate, and some substyles do it a lot more. You know, in some competitions, you do like a bout of fighting, and then you need to break boards in between bouts, and if you don't break them, you're disqualified. So you need to still have that kind of mental strength to power through.
Yeah, it's one of the reasons I brought it up, was that hesitation part that you just mentioned, being able to draw on that in your now career as a doctor, in those high pressure situations when you need to be switched on, and you need to make a split second decision. You can't hesitate because it has a effect if you do hesitate.
Yeah, and I think it's how much you back yourself. Yeah. There's a few things that I would take, you know, if I think something's getting difficult, I'll look back on and go, well, if I manage this, then this will be fine. So one of them is the third year of medical school, which is like the hardest year at Glasgow, where I went, and I thought, if I can do that, you know, everything else is no bother. And the other one was my third Dan karate black belt grading. I was the youngest in the club to ever do it. I did it at 19. And you know, it required a lot of training. You know, it was a kind of combination of 12 years at that point, and I basically just taught myself all the stuff I needed to do. So I always think to myself, if I can do those two,
yep,
everything else should be a breeze.
does having that outside of your kind of doctor work, I know you don't do it as much now, but does having that outside of that help you stay grounded in such an overwhelming environment such as the NHS?
Absolutely, yeah. It's a release. Do you know what I mean? So like you're either punching a bag, hitting pads, hitting air. I suppose in martial arts is the same. I mean, you'll know because you're quite into your boxing, but like exactly. I can't quite explain. It sounds bad, like how good hitting a punch bag feels. So you knock lumps at a punch bag for 2 minutes, and you're absolutely gassed at the end, and you go, I feel great, and everything else just kind of just fizzes away into insignificance. Aye.
Yeah. So touching more towards the NHS, obviously nowadays it does get gets a lot of slack, and it gets a lot of people kind of going in on it. And I think it's important to realise that you guys getting in the front lines, it's not your fault. Do you know what I mean? When waiting times are so long, and there's people in A&E, for example, and they're lined up in corridors, you know, it's not your fault. It's not like you're sitting having a coffee in a room and going, I suppose when we get to that, it's how does that feel for you? And do you ever get MD kind of coming at you? I mean, on the job?
Yeah, I mean, not directly. Quite often people are frustrated and they express their frustrations at who's in front of them. You know, which more often is us, and more often than that is the nurses. They can get a bit of flack as well, but you know, often once the dust settles, they realise, and they apologise, and they go, you know, it's not you that we're angry at, it's just the system in general.
Yep.
And people are generally very understanding. I think if you appreciate it, I'll always go in if it's hectic and go, I'm sorry you've been waiting for so long, and 99% of folk are fine with it.
Yep.
And they're quite sympathetic, and they realise that a lot of us are just doing our best.
So 63,000 people a year are waiting more than a year for treatment in Scotland. How does that backlog affect you and your colleagues on that front line?
Yeah, so I suppose I'm a GP trainee, so that's what I'm training to be, just for context. So, you know, we'll get people that are coming with the same issues that have been referred 6 months previously, and they're still waiting, and you're trying to kind of manage that as best you can. You know, they're needing specialist input, but you can't get it. I think it's quite difficult to manage them, and I think it's just a large part is managing expectations and saying, you know, this is the situation, it's not great, and kind of muddling through with patients, and they're often understanding of that. And I think what's necessary is you do your bit to maybe not refer to folk to specialists that you don't need to, and you think, I feel comfortable managing this with primary care, which is GPs, and secondary care is hospitals. So if I can avoid referring to secondary care, then I will. You know, if I can try and manage this through my own ability, and that's just making me better. That's how I manage that. So something I feel confident managing in, and that's just something that I develop. You know.
Yeah, and in terms of helping other colleagues, you know, people that have just come into that environment fresh, you know, they have done medical school, but they're coming in fresh to that environment. What's it like for them? Because obviously you'll know what it's like, but do you see nowadays people being more held back or more getting?
I don't know what it is about it when I see like medical students there at the end, or people that have just come into their foundation training where they're just junior doctors, like newly qualified. They seem a lot better than I was, to be honest. I don't know what it is, but like they all just seem really competent. Do you know what I mean? On the whole, and they're all really good.
Well, experiences, isn't it, as well? Like as we evolve as a human race, if you like, we're always learning new information all the time, and that'll be the same people coming on. You know, there'll be things that you maybe didn't do at medical school that you maybe did do in the field, and now that they can then draw from that expertise, that experience.
I think my medical school, like the latter 2 years were disrupted by COVID, so we missed out on quite a lot of time on the wards, or even when we were there was a limit to the stuff we could see and do, because it was kind of I started my final year in medicine in August 2020, right when that first lockdown was just waning, so yeah, we probably did miss out on a lot from that, and whether or not that had a knock-on effect, I don't know. But I think I'm caught up now, I hope.
Let's touch on a little bit of COVID. How did you find that?
It was different for me than a lot of my colleagues who are kind of above me, because they were working in that. So the year above me that I would have been, I took an extra year in medical, so to like a research year for an extra degree. So the year I would have been in, they got scrambled last minute and got deployed on the wards just before they graduated. And I think they didn't have a clue, what they were doing, but no one really did at that point, because that was kind of, April, May 2020 when COVID was new and it was fresh, and no one had a clue what they were doing. Do you know what I mean?
Even trained, nothing can prepare you for that, really, can it?
Yeah, folk were talking about it because they were on just a COVID ward with an anaesthetist, a gynaecologist, and just a GP that had been drafted in as well. And it was. People talk about it, and it just been really, really strange working with all these people from different specialties, managing stuff that they wouldn't normally manage, because they just didn't know what to expect or how busy it would get. And I was separate from that. I was still at home, I was still at uni, and all our kind of online, in-person learning just got chucked onto Zoom, and we did all like online lectures.
The birth of Zoom calls.
Yeah, that's when it all started, and I find it difficult to learn that way. I learn by doing. I don't learn by listening, so I think I found it difficult to learn that way. I just had to, knuckle down and do it my own way. Do you know what I
mean? In terms of COVID, since COVID, I feel, I don't know if it's just because it's now spoke about a lot more, but I feel that that's the real birth of mental health, anxiety. I feel ever since now, and that's not me saying it wasn't there before, but I feel it since COVID and since we came back from that, a real rise in people talking about their mental health, feeling that they're more depressed, feeling more anxious. Mm-hmm. Do you find that people are coming in with those states?
Do you mean in terms of like staff or just everyone in general?
Everyone in general.
Yeah, I mean staff, you can tell, I think in the kind of couple of years past that, 2021, 2022, the folk that had worked all the way through it, they were burnt out and they were exhausted, but I was coming in quite fresh. So I didn't have that same experience.
Did you feel a wave? Because obviously these things are like waves, such a massive thing like that has its ripple effects.
Yeah.
Did you feel that years after it went?
Yeah, it did, because there was a backlog to everything, so when folk were still having to isolate when they tested positive, that had a real effect on staffing. So there were wards of 28 patients that would normally have 5 nurses down to 1, maybe 2, and they were worked to the bone. Do you know what I mean? We were getting pulled, working above, at the level above of what was expected of us at that grade, just because there was no one else to cover, and we were just expected to muck in and do it. And that does have its knock-on effect, and in terms of things like, wait lists and all that as well. Everything got knocked back, and everyone was working overtime to try and bring that back down. And they've had some success with it, but there's still a long way to go. I think even since then, it's just kind of the general consensus from everyone that everyone's kind of needs when it comes to healthcare are more complex than they used to be. You used to be able to deal with a few things within a 10-minute appointment in a GP, and you can't do that anymore.
No.
And
I always find it's murder to actually get an appointment, and as I said, like I need to phone in the morning, and they'll be like, right, yeah, you phone at 8:10 or whatever. They'll be like, no, the appointments are full now. You need to phone back tomorrow or later in the day.
Yeah.
And if you try to get an appointment, it's murder, but you probably find a lot of people phone just for real reasons. This is not me saying it's not big, but you know, some people will phone for like a stuffy nose, and they'll be like, I need to see a doctor, and you're like, you're fine. You know, but other people will phone me more serious stuff and they actually can't get an appointment for it.
Yeah, well, I think it depends on people's kind of own experiences, because we get taught that if someone comes in with something that seems like absolutely nothing to you as a healthcare professional, you need to ask, like, you know, is there anything you're worried about? And if they go like, you know, I've got like a small pain in my side, and you think that's nothing, why are you here? And then they go, oh well, my dad had cancer and this was his first symptom, so that's playing in the back of their head. So you always need to, like, I think, be appreciative of other people's life experiences and think, you know, that's what's going on in the back of their head. So something that means absolutely nothing to you,
such as a stuffy nose, might actually be something that
they go like, a stuffy nose, you know, there's 1,001 reasons. One of them might be something serious that needs treated right now. So you don't know what folk are thinking, and you also need to be mindful as well of just people's general kind of healthcare literacy. Do you know what I mean? So like, you know, like health education in general. So some people just might not know, and you can't assume that people know. And that's part of my job as well as a GP, is to educate them, to say, well, these are the reasons that you don't need to see us, but these, if you have this and this, I would like you to come back. And then it's just about getting them to learn about what they do need help for and what they can kind of manage themselves. And then, you know, with that, appointments might reduce. Do you know what I mean? Yeah. I do actually have my own numbers. You come in with numbers, I've got some of my own. So
like
just an example when it comes to appointments. So the practice that I'm based in, it's a kind of medium to large practice, has about between 8,000 and 10,000 patients on their caseload, and they use an online system for appointments as well as phones, for a number of reasons. One of them is just so that it's easier to manage for the GPs that do it, and also to free up the phone lines for like elderly people that aren't as tech savvy. So see, on a typical Monday, they can get upwards of 250 appointment requests for that day. Do you know what I mean? And some of them will be house calls as well, which takes, you know, like an hour out of a clinician's time. And then if you boil it down, so 250 appointment requests, if you've then got, say, 5 clinicians working at 15-minute appointments, so 15-minute appointments is 4 an hour, 12 and 3 hours. They do that twice with a lunch break in between and a house call. They're seeing 25 patients in a day. So you would need 10 doctors to match those appointments. Do you know what I mean? And I think if you look at it like that, you know, find me a GP that's got 10 doctors, you know, so,
very few.
A lot of those requests will not get appointments, and some of them will have to be phone calls, which take up time as well, or they're managed via text. So I think for people that are frustrated that they kind of get an appointment, and I fully get that, you know, it must be so annoying if you've got an actual, you know, a problem that needs sorted and you can't get an appointment. You know, from our end as well, we're trying to see everyone, you know, and all of those 250 requests get something. They either get a text response, they get an appointment, or they get a phone call. They get something by the end of the day, and whether that's not what they truly wanted, you know, I think it's just about trying to manage the workload for the doctors as well. You know, it's a tough job.
Yeah, no, it is.
Long hours.
I guess it's underappreciated how actually difficult it is, and obviously that's the reason why medical school is so intense, because it needs to prepare you for that. Do you feel like nowadays less people are becoming doctors because of everything that's been on, because of waiting times, because of people, you know, taking 2 or 3 weeks, whatever, to get an appointment? Yeah,
I mean, I think actually medical school numbers are increasing, you know. So when I started, I think there was maybe 250 in my year, and then when I was getting to the end, they were having more than kind of 300 in a year group, which is a lot of people coming through. And then it's all based on, you know, how much the government wants to spend on employing new doctors, you know, because that's where the money comes from to fund the medical schools. Do you think we should be spending more? Well, it's funny because the year groups, the couple of year groups before that have just finished medical school, not all of them are getting jobs. There are not enough jobs for the people graduating, which I think is bonkers. You know, so you've got like trained professionals that have done at least 5 years of medical school that then are going out onto a reserve list because they can't get a job. And I think that is something that needs sorted. Do you know what I mean? Because these are people.
How would you sort it? Do you have an answer for it, or a suggestion, or?
No. I think you just need more money, don't you? But that's the answer to everything, isn't it? And it's not just doctors that you need. Do you know what I mean? You need more money across the board, which, you know, where you get that from, that's above my pay grade. You need more nurses, you need more people doing care. I think that's the big thing. You see folk just that are like fit, they're like in their 80s, they need someone to go in and help make their meals, and they can't go out of hospital because that's not there. And it frustrates us because we want them to go home. It frustrates them, it frustrates the family. Do you know what I mean?
It's just a frustrating situation all round for everyone involved, and you all want the best for that patient, but not being able to do it.
And the longer they're kind of sitting in hospital, they're not up on their feet as much as they should, so they lose the muscle mass in their legs. You spend a week in hospital and it takes 6 months to get the leg strength back if you're older. And you know, you're losing your independence as well, and then you get more chance of picking up a bug in the hospital, and then you're back in for longer. Do you know what I mean? So it just perpetuates the problem.
So A&E performance is sitting around about 66% for the 4-hour rule.
Mm-hmm.
Obviously you can explain to me in better detail, but the target's around about 90%. What is it like for staff working in those high pressure emergency situations, knowing, and obviously it's not running through your head, but knowing that the number like that is low and well below what it should be?
Yeah, so the 4-hour rule is that everyone that attends an A&E in the country is assessed, diagnosed and moved on within 4 hours. So whether that's you get discharged home or whether or not you go to another ward downstream, we call it the back door of the hospital. So front door is like the assessment units in A&E. So the idea is that you leave the department within 4 hours of arriving. And pre-COVID, you know, that was quite reasonable to expect that. Nowadays, you're waiting longer than that before you're even triaged. Do you know what I mean? And I see it that folk are waiting upwards of 24 hours, sometimes longer. If they're getting seen in, you know, if anyone's been to A&E, they'll see it themselves. They're getting seen in corridors and things like that, and it's dire, you know.
I think that's the big thing, and I see in the news is the people being, chucked out into the corridors, if you like. But you know, again, it's not your fault. You know, what are you meant to do with this person? What's the reason behind that? Talk us through that, because obviously it's something a lot of people see and actually never get an explanation on. Yeah,
it's all bed space. So you have bed managers specifically for this, and I don't envy their job at all, because it must be a very difficult job. But it's their job to try and figure out where folk go once they get into hospital. So once they've realised they're staying, they need a bed, and it's about kind of clearing one area so you can go into the next area. So you go out of A&E, if you're coming in, you'll go to the downstream ward, whether that's medical assessment, whether you go orthopaedics and so on. And you know, if there's no space there, they can't leave A&E, and there's no space in that other ward because there's no space in the further downstream wards, do you know what I mean? Or there's no space in the care facility that they're going to be discharged to, that sort of thing. So it's all just a pure backlog, and it kind of ties back to what I said before about there's a lot of need for care, and that's managing people within their own homes, whether it's in a bed in a care home, that sort of thing, because there's an ageing population and they're getting frailer. People are living longer, but that means they have more advanced care needs.
Yep.
So there's more required for them to be safe in their own home, and what you don't want is to pat them out too early and then they fall and break a hip in their back. Do you know what I mean? So that's why things take so long, so you want folk to be safe.
Yep.
But then what that ends up with is you get a queue at the front door and you have 10 ambulances outside, and you know, poor 90-year-olds are waiting 10 hours in an ambulance because there's no beds, and it's terrible. You know, it's terrible for all the stages of healthcare involved, and A&E staff. I've not worked in an A&E, but I've worked in the kind of departments that go to A&E to see the referrals.
So you're there or thereabouts, so you have it. You can
so I can see how it is. Yeah, and it's just every time I walk in, and it's just like, you know. It's just like overstimulation.
One of my clients is a surgeon. She works in the QU, and you know, hearing it from her, how difficult that area of the hospital is, or that department. You know, the stories she tells me. I don't envy you guys at all. You know, in whatever section, whether it's the receptionist at the front, the doctors that then see them, the other person they get passed on to. Mm-hmm. It must be hellish.
Yeah, and I think you can't fault A&E staff. Like they all work really, really hard. You know, and I don't think anyone's disputing that. Do you know what I mean? But again, you know, they get the burning frustrations because folk are waiting, and I think it's very difficult for folk to folk to be happy with the service, because it's not working very well.
Yeah. With the wait times, with everything going on with the NHS, a lot of people are going abroad or private for their care. How does that make you feel as somebody that's still working or still works in the public sector?
There's two ways to think about it. So if you're in a position where you're fortunate enough to afford private healthcare and that's something that you want to do, I'm not going to tell you to do it or not. Us as clinicians are very keen on autonomy, and that's you deciding your own healthcare, being in charge of your own healthcare. So if you want to do that, I'm not going to tell you to do it or not. I would just tell you to do your research and make sure that you're doing someone reputable, someone that's good and experienced. And I think if you go abroad, we've all heard horror stories.
Yeah, I've heard them as well.
People that get, mainly it's like aesthetic stuff, things like breast augmentations. I've seen those go terrible, ones that they get abroad because it's a bit cheaper and they come back and they go horribly wrong.
What's the worst one you've ever seen?
I've seen like breast implants get infected and need removed. And then because it's that, like the infection treatment was an NHS procedure, but putting them back in is not. So this poor woman got left with one breast implant in.
Yeah.
And I was like, we can't fund to put one back in for you. So she just got left, and it was just awful for her. Do you know what I mean?
Because she's put her trust in that and whoever was taking care of her, and to her she's signed whatever, and she's come away thinking this is brilliant, and then to have come back and then have that unfortunate news or see something going wrong, going this doesn't feel right. That must be horrible.
It must
be
terrible.
I can't even imagine how that feels.
The upside of private healthcare is it does reduce the wait times for people that can't afford it. For the people that need the NHS, and I'm a huge fan of the NHS, and I don't want it to go away, because I think healthcare should be universally available. And I would hate the possibility that we would move towards private healthcare, because I want it to be available for everyone, and I prefer treating people that can't afford private healthcare, the folk that need support, and I much prefer helping them. I find it far more rewarding. In a sense. So it is good that it maybe reduces the wait times slightly, marginally. It's got its place, I think.
Yeah, for sure. Something else I want to talk about was the privatising of the NHS. It's something that's been spoke about, quite a lot in the news by certain political parties. What's your thoughts on that?
Yeah, I mean, I don't claim to be an expert on that at all. But I mean, I would kind of reiterate what I said already about, I think the fact that NHS should be universally available for everyone, regardless of who you are. I think you should have access to healthcare because it's a right. Do you know what I mean? And it's our responsibility to provide that for people. And I get that, it's a large part of government spending, but I think it should be. Do you know what I mean? Because
people's health is important.
Exactly. And it's not just physical health as well. It's mental health as well. And as you said earlier, there's a big increase in recognition of mental health as well, and supporting that as well. And I think that if you're getting your physical health not treated properly, that then has a knock-on impact. Do you know what I mean? And
those ripple effects that we're talking about.
Yeah. And if your mental health is poor, we know that physical symptoms worsen as well, and you end up with like conditions like irritable bowel syndrome. It's very, very common, and there's no physical source for it, but there's it's all tied to mental health. So if you can sometimes fix people's mental health and fix their mindset and attitude, the physical problems improve as well. It's all part and parcel.
Do you think people use mental health as a getaway, a get out clause? Something I see quite a lot is the mental health card, as it's called nowadays. A lot of people waive it, but maybe not actually. They're just using it to say, I'm having a down day. What do you feel for people that maybe use it to get out? Because it obviously has an effect on people then. If you think about somebody actually that does have serious mental health issues and is really struggling, to somebody that, this is not me saying they are, but they're just using it as a get out.
Yeah, I've not experienced that personally, but it could also just be that we're noticing it more because people are feeling more confident to speak about their own mental health, and they feel less ashamed than they used to about, speaking about their own mental health and saying, I am struggling today, and I think it's been destigmatised a good amount compared to even like 10, 20 years ago. You know, I've had it myself where I'm like, you know, I'm not feeling right, and particularly amongst guys, you know, it's a lot more difficult, I think, for guys to talk about
their feelings.
but it's getting there, and so I think maybe it's more that folk are actually like feeling more comfortable talking about it, and you know, if you're not feeling right, you're not feeling right. Do
It's
you
the
know what I
elephant in the room, really, isn't it?
mean? Yeah.
It's the danced around, but you know,
I think it's very
if
important
you
to talk
are
about
actually
it.
feeling not good and you're not in the right place, you need to chat. You know, go to your closest confidant. You know, whether that's your best friend, your mum, your dad, your brother, sister, auntie, uncle, whoever it might be. It's important that you just go tell them that, yeah, you know, I'm not good.
Yeah, you know, I've personally have gone through a period of depression, and it's funny. I think the you say that, but they're often the hardest to tell about it. I think the ones that are closest to, I don't know why. I think sometimes they're the hardest people to admit that there's a problem, and I think sometimes there's a guilt that maybe they've not picked up on it. But I think people that do suffer from mental health, myself included, you become very good at hiding it.
Probably why you go to a therapist, isn't it? You know, the rise of the kind of the therapist and going to therapy. You know, I think it's got its place for sure. You know, I've myself been to a therapist quite a few times, and it's somebody that you don't know.
Yeah.
Speaking to them and getting somebody completely unbiased opinion.
Exactly.
Not even opinion, sorry, but somebody's just completely unbiased view, and getting somebody to listen to you and just actually going, do you know what? You are going through a bad time. It's okay to feel like that.
Yeah.
It's nice to hear that kind of confirmation or reassurance, if you like.
Yeah, and part of it, like the recognised management of depression, anxiety, stress, is that kind of those talking therapies. They work alongside the tablet therapies as well, and sometimes they're like as, if not more, effective in certain cases. You know, it's all individualised. That won't work for some people in the same way that tablets will work for some people. But it's very, very good, and it focuses on changing your own mindset to, you know, I'm feeling sad. Why am I feeling sad? Do I need to feel sad? That sort of thing, and it kind of works. Like that's the basis of it. If you really boil it down, but it's very, very effective.
Yeah, in terms of going back to the kind of doctor side of things in hospitals, a lot of them, clinics, buildings, have quite old infrastructure, old buildings. You know, obviously the QE is new. What's that like to work in those aging buildings? I'm assuming you might have been to one or two.
Aye, well,
does it make your job more difficult? What's the challenges?
Well, you say that like new buildings have their issues as well. So I think every building's going to have its issue. I mean, working in the Royal, and that is a dinosaur. That thing's about 500 years old and is in desperate need of being updated.
It would survive an atomic blast.
But you know, it's got these underground corridors that, like, genuinely, I feel a bit uneasy walking through at night. And you know, I've heard stories of people being like mugged in those corridors at night because they're open to the public. Yeah. Whereas the newer hospitals are maybe more, you know, better for security and all that. But like, one of the big issues with the new hospital, the Queen Elizabeth, you know, biggest hospital campus in Europe when it was built, it's all single rooms. If you've ever been in it, there's no bays.
Unfortunately.
And it's very, very good for infection control. It was great when COVID came around, because it meant everyone was isolated, but it means that older people who maybe would benefit from speaking to other people, they might struggle with that. And you know, it's less good for stopping things like delirium because they're getting isolated and they get in their own head, and you know, and then delays the recovery. And it's also very difficult to nurse because you can be like a solid 30-40 second walk from your furthest patient if you're a nurse, whereas if you work in a bay, you're there in 10 seconds. You know, so it's got its benefits and drawbacks.
Yeah, and the QE, to be specific, how is that now? No, I've not been in it for a wee while, thankfully, because I never feel like the hospital is somewhere you want to go unless you work there. There's never put it this way, there's very few reasons you go to hospital for a positive reason, apart from like a birth of a child, for example. You know, it is very much, you know, it's always the negative side of things. How do you feel that building is nowadays? Obviously it has its challenges.
When did I work there? That was 2021 into 22. So I've been there for a few years. And I think when it first opened, just the general management, it had a few creases that needed ironed out. And even then, I didn't particularly enjoy working there, but I don't know whether that's just because I wasn't doing what I wanted to be doing, which was general practice. You know, I was working as a junior doctor in the second wave of COVID, you know, which is maybe why I don't look back on it particularly fondly.
Yeah, what was those times like?
Mad.
Yeah.
Totally mad. Yeah.
I remember seeing you a few times, especially obviously when you'd PT'd with myself. I remember just how much work you were actually doing.
Aye.
I think, as I said, people always, you know, myself included, always go, it's not that bad, mate, just had a few hours sleep, but you're just like switched on constant.
Yeah.
I must have been.
The hours that you work some weeks. The worst one I think I did an 87-hour week one time. That was the worst one. 4 long days, 12 hours. You finish on Thursday night and you're back on Friday night to do 3 night shifts, and you finish on the Monday morning.
I think I've done 87 hours in about 3 weeks.
They don't let you do that anymore. The employment rules changed after that year for me,
that's
so
nice.
they don't let you work that much anymore.
I suppose that's good for the future though, isn't it? Like,
you know, the guys that came before me, they'll go, well, we used to work 15-hour shifts, so you know, the generation before had it worse. You know, as bad as I think it was. But you know, some of those like teams that I worked with, I remember quite fondly. Because, like, you know, the nurses and the doctors, both junior doctors, consultants, you get on with them, you know, because it's like, you know, you're in the trenches, aren't you? So you get on with them, and you form quite good like working relationships with them, and you have a laugh because you kind of have to. Do you know what I mean? If you're working somewhere grim.
Yeah. So, in terms of the future of the NHS, doctors, GPs, nurses, what does the future look like then? Do you think for the NHS and for, you know, medicine practice as a whole?
God knows. Do you know what I mean? I honestly couldn't tell you. I think.
What's your hopes? What would you like to see? You know, because you're obviously you're in it. So
yeah, I just want to see it keep going. Do you know what I mean? I think the NHS is a great thing, and I love it. You know, and I love being a part of it. I find it very, very rewarding, and I do enjoy my job as much as I sounds like I might have complained about it. I do really enjoy my job. I find it very interesting. I love working with the people. I love working with the patients, you know, and I think it's the people that will keep it going. Do you know what I mean? And I think, you know, it's as long as it's needed, it will be here. I think it's here to stay. I think, you know, things will obviously need to change, and you know, it's evolved in its 70-year lifetimes, and it's going to continue to evolve as the care needs of the population evolves as well. You know, the population now is vastly different from what it was when it started in the 50s. You know, you know, life expectancy is about 30 years longer now. Yeah. So yeah, it will evolve with that. You know, new departments will come up. You know, that will as and when it's needed. You know, and in terms of things like, you know, cancer survival rates, there's constant research. There's really, really clever people, far cleverer than I ever will be, finding cures for things that at the moment we can't treat. And I'm excited to see what that will be like, you know, over even the course of my career. There'll be stuff that is now a death sentence now that will be fully treatable, hopefully. You know, the biggest example is like cervical cancer. You know, when that HPV vaccine came in, you know, I don't know if it was true, but I was told, you know, by the time you finished your career, Gillan, in, you know, 40 years, you probably won't see any deaths from cervical cancer because that vaccine has almost gotten rid of it, you know, and there are real positives in it. So, you know, I'm an optimist. So.
Yeah, no, you've always been an optimist. That's what I love about you. Listen, mate, thank you so much for your time today. Really appreciate it, and yeah, hopefully catch you soon.
Aye, absolutely.
Cheers, mate.
Thanks, mate.